the cameras are here. We are moving to the second part of today's lecture, and I'm very happy that we have with us our own Professor Jacob Goldenberg, Professor of Marketing at the Arison School of Business, who will be interviewing Professor Yoram Louzoun, who is at the Department of Math at Bar-Ilan University, but importantly to the current context, he is also a member of the AI team at the Administration for Research on Development and Technological Infrastructure, that is Mafat B'Ivrit, and is directly involved with various aspects that relate to managing the corona crisis in Israel. And I think we are all eager to hear their take on the matter. So Jacob and Yoram, the floor is yours.
Okay, let me start quickly because I'm not going to do the talking. Yoram will. The idea was of having me hosting Yoram because it's a big privilege to have him. Beside these credentials, I can tell you that he's doing research extremely bold and important on genetics, on spread of things over social networks. It could be either epidemics or news or anything very relevant to business, his research, but also life in general. So he's a real expert in this area. And this is why I wanted to host him. But during the preparation this week, I realized that actually the more I talk, the less you learn. And therefore, what we are going to do is something different. I will not be interviewing. Yoram will just tell you things. However, I'm going to monitor the chat room. So try to behave in the chat room as at the end of the previous lecture, ask the questions. I will see whether the questions are relevant and interrupt Yoram once in a while asking the questions, or just let it go because I know that either he's going to answer or it fits more the Q&A at the end. So Yoram, your stage, please start.
Okay, Yanko, thank you for this really long list of slides. And it's a real pleasure to be here. I don't know if I do anything really interesting in life, but I do fun stuff. So I think that's good enough. So Yanko invited me to talk about COVID, and there are so many aspects to it, and we actually didn't know what aspect to talk about. So we decided to do something which is really rare in this last 3 or 4 months, which is to stick to facts. And so we try to give you some facts about COVID. We won't try to amplify or to scare anybody, and we won't try to say that nothing is happening. We'll just give you a long list of facts that would give you some tools, I hope, to better estimate and gauge what's going on. Now, it's a really open session, so I'll be really happy to take any questions, and even during the talk, I mean, no need for you to wait to the end, because by the end you probably forget half the questions you had to ask. So really feel free to interrupt. And what I'll do is I'll give you a few basic initial numbers about COVID, and also I'll give you at the end what these numbers made to society. And then you feel free to judge if we're living in one of the worst epidemics that humankind ever knew, or if we're living in one of the worst global psychosis that humankind knew, or perhaps something in between. So let's start with a really short history. COVID-19, as its name states, actually started last year in 2019. And what you're seeing here in the figure is the total number of cases, the daily total number of cases all around the world. The map that you're seeing is the current status of a few days ago, of April 22, which is when we prepared the slides. And the graph below is a time history of the disease. Now you can see actually 3 really important facts about that. The first important fact to see is that the disease in China was tiny. I mean, it was really small compared to what's happening in the US and in Europe. So basically the disease is a Western country disease. It indeed started in China, but it actually spread really, really fast to the other parts of the world. I know it's really hard to see, but if some of you have a really sharp eye, you can actually see here the small blobs of yellow already here very, very early in the spread of the disease. So actually COVID-19 was in Europe quite a long time ago, actually almost from the beginning of the disease. And people actually suspect that it started somewhere at the end of 2019 or perhaps at the beginning of 2020, even in Europe and perhaps even in the US. So that's the first thing that's important to see. The second thing that's important to see, which is somehow
I'm sorry to interrupt, but I don't see the share screen, and I'm not the only one. So maybe you can fix that.
I see it actually very good. So I think the problem might be...
That's complicated.
All right.
So let me... Do you see the share screen now? Yes, perfect.
Yes, thank you.
Sure, you're more than welcome. The other important thing to see is that the epidemics basically stopped. I mean, it stopped growing like basically at the beginning of April, that's the 1st of April, and the epidemic stabilized all around the world. Why? I don't think anybody really knows. Now, a friend of mine told me once that if there are 50 models to explain something, they're probably all wrong. So practically everybody has its own toy model to why the epidemic stopped. I don't think that anybody can really say that his toy model is actually truer or true in any way, because it's all ad hoc models. We don't really know, and we don't have any kind of evidence to explain why it stopped. But the basic fact is that worldwide, the epidemic stopped, but in a strange way. It's not disappearing. It's not starting to, I mean, you don't see a really fast decreasing number of infection. It actually stabilized. So we're somehow in a stable state where the number of new sick people per day is constant for quite a long time now. And that's a pattern we're seeing all over the world. While in classical epidemics, you would expect the epidemics to get to a peak and then decrease back to zero. The interesting pattern here is that we got really, really fast to a peak and then we stabilized. So actually that's one of the really interesting questions in these epidemics is why? Why is it stabilizing? And why is it not getting done? Now, again, a few numbers about COVID, which may explain.
There are many questions in the chat.
So Yanko, I'll follow you. So Yanko is the boss here.
Actually, I'm answering some of them in the chat, so you can read also. Most of the questions trying to understand whether the flat lines mean that that we really stopped it, or does it mean something else?
So now we're getting, I mean, initially we said that we're going to stick to facts. So now I'm giving you my own personal interpretation, which is as ad hoc as everybody's else personal interpretation. But my personal interpretation has two components to it. First, it's probably stopped. So it stopped in the sense that we don't have an exploding epidemic anymore. Also, we keep sampling more and more people. And initially we sampled very, very few people. Now suppose, and that's a reasonable ratio, suppose we only sampled a fifth or a tenth of the infected population. And now nobody gets infected anymore for a really long time. So then what's going to happen? We'll keep sampling new people and we'll keep finding people that were infected already a week and 2 weeks ago. So every day that we sample people, we'll keep finding new people. So there are two aspects to it. A, there are still new infections, but B, many of the new infected people that we find are actually people that were infected a long time ago, and we start filling the gap between the infected people that we sampled in real time and the infected people that we didn't sample and only now sampling them. So going back to a few more numbers about COVID, which pushed the initial scare. So the number that was the most frightening is the number here at the bottom, what's called the CFR, the case fatality rate. So for flu, for seasonal flu, the CFR is around 0.1%. So 1 in 1,000 persons that gets the flu would die. And actually flu is one of the main death reasons in the West, because tons of people die from flu. Formally they die from pneumonia, but de facto it's a flu that became a pneumonia. The initial estimate of the case fatality rate of COVID-19 was somewhere between 1 and 3.4%. Now you can see what that's making. So suppose that COVID-19 would spread to the size of the flu, which is 10 to 20% of the population. You take 1% to 3.4% of that, so let's take 2% of that. You get 0.4% of the total population that dies. And now that's a lot. And that's one of the reasons that COVID-19 made such a huge scare. Now I must say that those were the initial estimate of the WHO, which were mainly based on Chinese number reports from the initial reports in China. However, these Chinese numbers were wrong in a few ways. First, they underreported the number of infected people by quite a drastic factor, but also actually on the other hand, they underreported the total number of deaths. So one of the main reasons that we're so afraid of COVID-19 was the idea that so many people are going to die. The second reason, which was actually the more acute reason, was the number above, the hospitalization rate of COVID-19. Around 20% of the people reported to be infected end up being hospitalized. And again, that's early number, because as I'm going to show you in a few minutes, these numbers are not really relevant anymore. But those are the numbers that push the world to where it's now. So 20% hospitalization mean that the health system of the entire world, which is already quite crowded, would be overpowered by COVID, and we would get a complete collapse of the health system. And actually, if you really talk to health practitioners, the main scare was more the collapse of the health system and the idea that people would get to hospitals and you can't take care of them, than the fact that a lot of people are going to die. And the reason that people were not really afraid of a lot of people dying is the graph here to the left, which is that in contrast with flu, COVID, the main damage of COVID is to really, really old population. So it's indeed dangerous, but it's really mainly dangerous to very old people. And so that results from Australia, and that's against prediction, because none of these predictions end up being true. And that's a prediction of the percent of the total population that's going to be affected. And you see, when you see the blue lines, that's without COVID, and the orange line is the extra element of COVID, in practically all ages up to 70, you don't see anything. But you do see a dip in the populations. And the estimate from Australia was that 11% of the really old population, so the very old population that makes 11% of the total population in Australia, actually will be in charge of 60% of the deaths. So, and I'm sorry to say that, and that's not politically correct, but the fear of a lot of very old people dying was less a factor in many of the decisions taken than the fear of the entire health system collapsing, with tons of people knocking on the doors of ICUs and nobody can take care of them. And some pictures from Italy actually made this fear more realistic or more sensational. And finally, the two other numbers that we have to understand about COVID are the R0 number, which is how fast the epidemic spread, which is twice as fast as flu. So a typical flu patient infects 1.3 other people, while a typical COVID patient infects between 2 and 2.5 other people. So these numbers actually led to a really, really large-scale scare in a lot of governmental agencies, and mainly in the WHO, which tried to convince everybody to take really drastic steps. However, in reality, we didn't have a really, really large fraction of the population dying. Actually, and that the total number of deaths all around the world, okay, and it stabilized again already 3 or 4 weeks ago. So we do some peaks. We do see some peaks here and there, but basically it rose exponentially and it completely flattened. And it didn't flatten at a really high number. It actually flattened at a not very high number, which I'm going to show you in a few minutes, is much less than most things that are killing us. So we had all these really frightening predictions from basic numbers that we got from China, and then reality was completely different. We ended up having a few thousand deaths, around less than 10,000 deaths per day by COVID. Now you may say, well, 10,000 dead per day is really, really a lot. I mean, that's a lot of people dying, okay? Not only that, but you see, and you keep seeing these graphs all around, you have a lot of dying people all around the world. It's not really limited to a few places. It's mostly focused on Europe and the US, but you have them all around the world. However, when you actually compare that to the total number of people dying, say in Europe, it's actually really, really small numbers. So just to give you an idea, so every year in Europe, we have between 5 and 6 million people dying. Most of those, and the total loss of COVID is expected to be, when we accumulate it to the end of the spread, with current estimate, is estimated to be around 200,000 numbers. So a really small fraction, not of the population, but a really small fraction of the total number of people dying in Europe. And the vast majority of people dying in Europe would die from cancer and eating too much, basically. So, and actually putting everybody in their house may make at least the last element much worse in Europe than it was before.
Yoram, I want to interrupt you. There is a question by Yael in the chat, and it might be relevant. Maybe you want to answer a little later, but would you agree that the strategy that of lockdowns and everything is behind these numbers, and whether effective way in going back to some sort of normal life?
Can I elaborate?
Sure.
I'm sorry. It just means that based off of the sorry, based off of the R, since every place has technically a different R, and every person also has a different R because people are affected differently, and each place is affected differently. Like the beach, it's an open place, and you're most likely not going to be in physical contact with people you don't know. It has a lower R than being in a wedding hall. So do you think that if countries start loosening up the restrictions based off of each place's subjective R, do you think it will be effective?
Okay, so I was planning on answering that later, but I'll still give you an initial answer. And again, the goal of the talk was to stick to facts. So now what you're hearing is my opinion and not facts. But still I'll give you my opinion. It's clear that the initial steps taken all around the world for social distancing had a strong effect on limiting the spread of the disease. And I don't think that anybody argues about that in the world. So almost everybody asked people to start doing social distancing. So stay a little bit further one away from the other, increase their personal hygiene, for example, not drinking together or not eating together from the same plates, all kinds of basic things. But
Yoram, people ask what is R.
Okay, so but let me answer Yael, and then I'll go back to answer what is R. But there is a law of diminishing returns, which means that the really simple and easy initial steps had a crazy effect. They actually drastically diminished the spread of the epidemics. And we'll get to the example in Israel, but for example, in Israel, I think almost everybody now agrees that what stopped completely the epidemics in Israel is closing the schools. Once you close the schools, you actually stop practically all the spread between kids, which was, well, in charge of 90%, if not more, of stopping the spread of the disease. Actually, interestingly, when you talk to clinicians and practitioners in the community, they tell you that not only COVID-19 stopped, but tons of other diseases disappeared because the kids don't go to school anymore, so they don't catch diseases there. But the extra steps have a drastic diminishing return. So you do extra steps which are much, much harsher, but the return on each step is becoming much, much smaller because anyway, you've already stopped most of the spread. And now you can actually start trying to stop more and more, but since you've stopped most of external contacts, then it actually doesn't really help anymore to stop that more. So, and going back to the other questions that Yanko asked.
No need, we took care of this.
Okay, but that still didn't answer the question of that, like answer the question of the initial steps that we took. I'm talking about getting like to go back to normal. How do you think the R will impact?
So I'll give you an example from yesterday, which was really, really shocking. So we had a meeting and everybody was really, really polite and kept its 2-meter distance and wore their masks. And they were really adhering to all the extreme steps taken. And then at the end of the meeting, somebody served food. So there was a plate of food, and what everybody did was to put their hand in the food, put the food in their mouth, and put their hand back in the food. Okay? And so if you're talking about going back to normal and losing the extra hygiene that we got during this last epidemic, I think that would be really bad. I think that you still need to keep quite strong extra measure to limit the main effect of the spread, which is through droplets and through body liquids that you pass from one to each other. However, most evidences suggest, and again, we don't have strong facts about that, but we do have a lot of examples from all kinds of other countries. Most evidences suggest that even if you go back to relatively easy measure, which ensures social distancing at a reasonable level and ensure a much higher level of hygiene that we had before, we don't really expect a pop back of the disease. Okay, so going back to the scale of the disease. So again, just to put things in scale, COVID is expected to kill up to 2, or in the extreme cases, 300,000 people in Europe over a period of approximately half a year. During this period, around 3 million people would die in Europe from all kinds of other reasons. Now, people die from obesity, and we don't close supermarkets and still allow them to eat. People die from cancer, and much of it is due to cigarettes, and we never really banned cigarettes, and so on and so forth. So I mean, again, sticking to facts, we're living in somewhere in intermediary regions. So it is an epidemic.
Can I comment about what you just said? Is it okay?
I don't know if Yanko is leading the...
Actually, we're a little behind the schedule, Yoram, so maybe we'll give you about 10 minutes without questions. I'll try to answer some questions through the chat, and then we'll go back to...
So perhaps I'll try to move much faster, and then we'll have tons of time, or however much time we have for questions and answers.
Until Shabbat.
Yeah, well, that's... okay. So just to give you really short estimates, okay, the number of people that are going, so the death rate of pneumonia in Europe is 30 per 100,000. The European Union has now around 450 million people. So we expect just 2016, but that's close to the current estimates too, around 130, 150,000 people dying from pneumonia just in Europe. Heart diseases would be 3 to 4 times as much, and I'm not talking about cancer, which is even much more than that. So again, just to put things in scale, it's bigger than flu, but it's much smaller than all the important reasons of death in Europe. Now, just to put things in proportion, in China, during the peak of the COVID epidemics, COVID was the 49th reason for death in China. So there were 48 other reasons of death that induced more death cases per day than COVID. So if somebody tells you that COVID is just a flu, no, it's worse than a flu. It's worse than a seasonal epidemic flu. If somebody tells you that COVID is the worst epidemic that humankind saw, no, we're really, really, really far from that. Just to get some ideas, malaria epidemics in 2015, not a long time ago, killed 500,000 people just in Uganda, which is not far ago. Okay, the HIV epidemics in the 80s killed a few million people. I mean, you can see here a list. We had tons of epidemics in really recent history with way more people dying from that. And actually, the really interesting one is this one, the worldwide cardiovascular disease epidemic, which is now estimated to kill between 17, that's slightly older. Now the estimate is between 17 and 20 million extra deaths per year, in way larger than even the worst predictions from COVID. Just to get you an idea, and that to push you to go running outside after the end of this talk, an extreme BMI reduces in average 15 years of lifespan. A high BMI, so being obese, reduces your lifespan by 6 years. Okay, and that's not just the people infected, that's the average lifespan of everybody that's obese, and we're talking about tens of percent of obesity in many developing and developed countries. So again, to put things in context, it's a strong flu, but it's far from being one of the worst epidemics. Now, there is a really other interesting aspects to COVID, which is the difference between countries. So there are two differences between countries. So as you can see, if you take every single country by itself, then most countries have stabilized or are going down. Okay, so Israel, for example, is really low and it's stabilized. The United States has stabilized. Europe, most countries, it's starting to go down. Germany, it's stabilized. So the numbers are zeroed to the first day that they've reached five deaths in the same country. So it did stabilize. But as you can see, the slope differs a lot between countries, and the paths differ a lot between countries. So there are many either socials or genetic or behavioral aspects that make the dynamics of COVID very different between different countries. And why is it important? Because the main argument that people raise is, look at Italy. But you see, countries are really different. It's us, I mean, Lev Muchnik, which is probably one of the smartest people I know in this domain, gave me this great example. He said, looking at Lombardia and thinking that everybody else would be like Lombardia is like selling books from your garage and thinking that you're going to be Jeff Bezos. I mean, not everybody selling books from his garage will be Jeff Bezos, just like not every country having an epidemics will be Lombardia. The other important difference, and that's a huge difference, is the case fatality rate. So we discussed that in the beginning. The case fatality rate is the ratio between people reported sick and people dying. Now, this case fatality rate differs a lot between countries. So for example, in France and Italy, it's above 10%. So 1 in every 10 person that's reported to be sick, to have COVID, will die. In Israel, it's less than 1%. Now take into account that that's people reporting to be sick. That's not people actually sick. So we do know the denominator. We do know how many people die, but we don't really know how many people are really sick. So for example, places like France and Italy whereas actually sample very, very few people, you end up having a CFR really high. While Israel, which samples quite a lot of people, actually it's one of the places we sample per person the highest number of people every day, we end up having a CFR to be really low. And even that's obviously an overestimate because we still undersample the population. So the total number of carriers is way, way larger than the total number of reported carriers, while the total number of death cases is actually very close to the real number of death cases. So we have two main reasons that you cannot compare countries. First, the epidemic itself is very different between countries, and also the outcome of the epidemic is very different in different countries. In some countries, many people die, and again, we don't really know the reason. And so I can invent a model, and you can invent a model, but that's going to be guesses by now, because nobody has really managed up to now to bring a convincing explanation, nor has anybody been able to bring a convincing explanation for the different slope. For example, you see Mexico here has a really fast rising CFR, and nobody really has an answer for that. And actually, I think that's a right moment to stop and to say that if COVID-19 taught us one deep lesson, it is how flawed and how inexperienced is current science with estimating and understanding epidemics. We sought to really understand how epidemics work, and this epidemic showed us that practically all the models we had were completely wrong. But we still do have some estimates. So we have quite a few countries with a CFR of around 0.2%, so close to flu, and the top countries we get have a CFR of 10%. So just to explain this graph, the x-axis is the confirmed cases of COVID, and the y-axis is the deaths. So the ratio between the two is the CFR, so the fatality rate, the fraction of people sick that end up dying. And as you can see, it has a really wide distribution, starting from 10% here, all the way down to 0.1%, like flu in some countries. So again, going back to the comparison with flu, it may well be that although COVID was more infective than flu, it's not more deadly than flu. We just undersampled the people that had COVID. If that's the case, then our scare of COVID is even more unsupported. But still, we don't really know. And again, I'll repeat that over and over again. There are some facts that we know, like the fact that COVID stopped and it's decreasing. There are some facts that we don't know, like the fraction of people dying from COVID, or the reasons it stopped, or the reason there are so many differences between different countries. However, there is one thing that we do know, and it is that there is a clear relation between undersampling and high CFR. So you can see here, for example, the number of tests performed. I mean, perhaps here it's the best way to look at it. That's the cumulative, and that's not a cumulative. So that's the number of tests performed by per thousand people. So you may ask, so what the countries that sampling the most? Well, by far, it's Israel. Israel is one of the countries where we sample per 1,000 people every day, the highest number of COVID tests, which actually means that the fact that we have such a low CFR is probably because the epidemics in Israel is better represented and better sampled than practically any country on earth. And again, you have to remember the law of diminishing results. The more you sample, the less efficient is the next sample that you're taking. Sampling twice as many people would not help you, would not increase your detection rate by a factor of 2. It would increase your detection rate by 10 to 20%, because at the end you sample people that the chance that they have COVID is actually really low. And you can see that here, where you can see actually the number of tests you need to do to detect one COVID patient. In Israel, it's almost 20, while in Italy, it's around 8, and in some countries, it's around 4. And finally, just talking about the difference between countries, So, you know, Italy and France and Spain and England are all big countries. And so you may say, well, but there is a huge COVID spread in Italy, but that's wrong. You see, there is a huge COVID spread in Lombardia. There is a huge COVID spread in the London region. And there is a huge COVID spread in New England and New York and in Louisiana. But there is no huge COVID spread in the US, same in Spain, same in Britain. Many regions have really, really low numbers of COVID, even in countries which report very, very high numbers. So basically, and that's again something that nobody has a good model for, basically COVID is very, very localized. Why? Again, that would be guesses and not facts. And the last slide in this set of slides is that COVID also doesn't really, I mean, we've seen a place, COVID doesn't really affect all persons equally. I mean, in Israel, it's quite obvious. I mean, if you would see the list of cities infected by COVID, then it's really, really mostly poor cities. So obviously, extra religious cities are more infected, but also a lot of other poor cities that are not really religious. So it's a poor man disease, which goes back to what we initially said, that the main steps taken, which is to increase the personal hygiene and to increase the facilities to make sure that you don't transmit body liquids between either family members or neighbors, are the main steps that stop the disease. So for example, here you can see how it affects blacks and whites in the same place. And finally, to the questions of, well, Yanko, how am I doing with time?
Better than before, but still I think you should talk because there are a few questions that I don't want to answer. I wanted to ask you.
Altogether, we have
And they're
until
waiting.
2:30.
How much?
Until 2:30, including all the Q&As.
Okay, so I have no clue what time is it, but...
Now you have 20 minutes. If you keep talking, it will be 19.
Okay, so I'll stop talking. So finally, I want to give you an important answer relating to the steps taken. So again, if we stick to facts, there are two facts that we do know, which is that the time from infection to death is around 20 days. Okay, that's the estimated time from infection to death. And we do know when the different European countries started taking steps. And you see that's in March. So lockdown was ordered in most European countries around between the 17th and the 25th of March. Now, if you look at different countries and see when the disease stabilized, so for example, take Spain, the disease stabilized in around March 21. If you go 18 to 20 days before that, there were no steps at all taken in Spain. So that's this. If you want to know when did people get infected, go just 2.5 to 3 weeks before and see what happens there. Okay, you can look at Austria. Austria, the disease stabilized around March 25. And Austria did install a lockdown, but it installed it just 4 days before. And 4 days before cannot account for the stop of the disease, okay? You can actually check country by country in Europe and see that in almost all European countries, the spread of the disease stopped way, way, way before the lockdown. But in some countries, we can clearly see that it stopped approximately when self-isolation of people that were infected started and social distancing was encouraged. So if you ask, do preventive steps help? Probably yes, okay? Do you ask, does lockdown help? Probably no, or at least we don't have any fact-based evidence that it helps in any way. And just to give you an idea from Israel, and that's a really nice slide that we produced with the help of the Ministry of Health, which is how many contacts do we have outside the family in the extended family and inside the family. And you see that approximately in mid-March, most of our contacts were already within the family. And all the steps that we've taken from there increased this blue part, because we keep meeting our family more and more, and decreased this yellow part, but this yellow part was already quite small anyway. So we're taking extra steps, hammering on the part that has a small contribution, while we're actually increasing the part that has a lot of contribution to the spread of the disease. So for example, here you can see the number of dead per day in Israel. So it stabilized also around the beginning of April. So again, going 20 days before that, the infection stabilized around the 13th of March. 13th of March was approximately 2 days after Purim. So once big and major events of contamination stopped, then contamination stopped. Since then, we don't see practically any change. And an interesting change is when you check where people were infected, so there is no really big change in infections in all other places, but there is a huge increase in infection at home. So what you do when you do lockdown is that you prevent people from getting infected outside, and instead they get infected at home. And so then you can ask, okay, so if these steps are extreme steps, then are the people taking them full? So they're not full, and they're frightened by scientists making crazy predictions. And I typically don't like to name scientists, but in this case, there is a specific group in Imperial College led by Roy Anderson and Neil Ferguson, which keeps making these crazy predictions. Like they made the prediction that the bird flu pandemic would kill 150 million people. When it ended killing a few thousand people, they made the prediction that mad cow disease would kill in the UK around 150,000 people, where it ended killing just a few tenths of people. And they made a prediction for the current spread that, and you see it here, that COVID would really rapidly kill hundreds of thousands of people in the UK and in the US. And all of these predictions were really based on very, very simplistic modeling that assumed that society never changed, spread never changed, everybody is the same, like people said earlier, the R naught of every single person is the same. And based on this prediction, they make frightening statements, and then decision makers listen to these statements, spread them in the news, which leads to the conclusion that we're seeing. So people are not stupid, they're just led by very, very frightening worst case scenarios. And one last question, which emerged in the last few days, which is perhaps we're already mostly immunized against COVID. And more numbers emerging from the last 3 or 4 days report that there is a big fraction of the population that may have an asymptomatic case of the disease, and that's already immunized. Now, to check that, you need surveys. And we have like a few surveys for the last few days. For example, a pregnant woman that got to hospital were tested, and certain percent of them had the virus and no symptoms at all. In Iceland, 1% of the population was detected to be positive, where they practically had no COVID pandemics. Boston, house homeless have 36% positives. You can see many of those just from today. On the USS Roosevelt crew, 20% of the crew has been positive. In New York, in supermarket, they tested just people getting to supermarket, and they found 20% of them to be serologically positive. And there are more and more claims now that actually the virus has been here for quite a long time. And many of us may be actually positive without ever knowing that we had the disease. So to summarize where we stand just with facts. COVID is much worse than a flu pandemic in every year. It's making more dead people than a typical flu pandemic. COVID is much, much smaller than most of the pandemics we had and currently have in the West. Mainly the obesity pandemics, but other pandemics that are still killing a lot of people all around the world. COVID has stopped in the vast majority of places, and it has stopped way before the lockdown, but probably following the initial steps of social distancing and of increasing personal hygiene in many places. Unfortunately, we have no really convincing model nor explanation for why did any of these things happen. So we're in an interesting scientific situation. We have a very, very large of new open questions for science to try to answer, and I hope that we'll manage to answer them before the spread of the next epidemics. So thanks for the host, and Yanko, I really enjoyed that. And thanks for the audience. And I'm
of course we'll enjoy that. I want just to drop a note and then start to open this to questions, including one that I remember from the chat. But just a comment that there are already tens of thousands of papers, scientific papers, but the vast majority is on the biological aspect and not the spread itself. So the questions are still unanswered. And there was a question, I think it was by Tamar, I'm not sure, that if it is stopped, then why should we expect, or why we are expecting a new wave later or in the winter? Why necessarily the winter?
So that's a great question, but that's two separate questions. So let's start with the winter. COVID, like any RNA virus, is mutating a lot. It's every time it's transferred to a new host, it's mutating. And like every RNA virus, during a year, it managed to mutate enough that even persons that were immunized against it last year can still get it next year. And I'll give you a simple example. When you're congested or when your throat, it's a virus. Very often it's a coronavirus, not this specific coronavirus, but it's a coronavirus. But how is it that you can get the same disease over and over? Or the simple answer is, it used to be the same disease, but it mutated. And by the time it's coming back, it's different enough that your immune system doesn't recognize it. So since COVID is with us now for quite a long time, and there are around now between 30 and 50 different strains of COVID, and each different country has different strains of COVID, we do expect that by next winter, a new strain will get in, and we start reinfecting people just like it happens with flu or in any other disease. That's one worry. The other worry, and that has more to do with psychology and less to do with epidemiology, and it is that if we go back to normal, we really, really fast lose even all the basic steps that we've learned to take to prevent spread. And then we could go back to the initial spread rate, which was really, really high. And then the current COVID may pop up and emerge again.
Okay, I suggest instead of me monitoring now, because Yoram is free to take questions, just unmute yourself and start asking.
Hi.
Hi.
About schools, is there any estimation of what needs to be, what are the criteria in which we will allow schools to operate again, and under which conditions?
To be honest, it's way above my pay grade. I mean, that's political decisions. Obviously, kids are really, really hard to control. So you can't really prevent kids from touching each other or force kids to have a high level of hygiene. So the only thing I can say about that, because that's obviously not my decision to take, and we don't really have any facts to support what would happen if we would open schools. So the only thing I could say about those is that schools are probably the last things to get opened. Their impact could be really, really dramatic, and kids are the hardest to control.
Weren't Ganim, there was like a list of phases that was released, speculation of how it's gonna, the regulations are gonna be loosened, And they said that in the first phase, it's going to be either the first or second phase is going to be like kindergarten, like ganim, kindergartens, like elementary school.
Yeah, so again, the reason it's done by phases is that we don't really know. Again, science, although we claim to be really smart about predicting what's going to happen, we're really lousy about predicting what's going to happen in this disease. So the fact that everybody is taking baby steps is because since nobody really believes predictions, people just want to see facts. So they want to open schools in a limited way or in as much as possible controlled environment and see how it actually affects the spread before opening other things. Now, kindergartens and small small groups like pautonim, I don't know how you say it in English, are the easiest to control.
Daycare.
Daycares, yeah. While regular schools and especially high schools are the hardest to control. And so since basically it's all about preventing passing body fluids between different people by spitting, eating together, or staying too close, then the steps that are taken to let people back to life are trying to live on the really, really narrow margin of we know that with the current steps, we're overreacting. We know that with no steps, the disease would spread really fast. So we're really trying to find a fine equilibrium between letting people live their life and preventing the disease from spreading really fast.
I have a question. Do you know of any indication that small kids are not infecting adults? There were a few like reports about it.
Not only there are no proofs for that, but there are quite many events where we actually know that small kids infected their parents.
Okay, thank you.
So not only that I don't know about any such claims, I definitely know the opposite.
Can you maybe please an overview about collecting data from the WHO? Because there were many rumors about the biased attitude that they have towards specific countries and trying to...
So that's a great question. So I don't know, somebody once said that never attribute bad intentions where stupidity could be used to explain things. So the WHO, I mean, I don't know, or I don't know if they have any bad intentions. But currently, all the data collected by the WHO is by country standards. So I'll just give you two examples. In Israel, even if you're really, really coughing and really sick and have fever, and you were never in contact with anybody having COVID, they won't test you for COVID. I mean, they used not to test you for COVID at least a few weeks ago, or at least up to 8 days ago. And so Israel would only report cases to the WHO that were in accordance to the rules in Israel. In Iran, they're testing practically nobody. In Italy, they're only testing people in the hospitals. So every different country has different styles of defining who's sick and who's not. They use different kits. So the rate of errors in the definitions are really, really different. Not only that, but in some countries, like in the US, even if COVID was a second or third order reason for your death, you'll be marked as a COVID patient. For example, you're under chemotherapy, you have a lung cancer, okay? And you died from lung insufficiency. And you had COVID, then you'll be marked as a COVID, that's a death by COVID. Although COVID wasn't really the reason you died. The reason you died was that the cancer was killing your lungs, okay? While in other countries, you only are marked as dead of COVID if COVID is the main reason of death. The only thing the WHO does is collect what all the countries are giving it. So it's definitely biased, very, very biased, very country specific, but that's not because the WHO wants to hide something for one country or the other. That's because how the WHO works, which is to adhere to each country standards, which are very, very, very different.
Yeah, so can I ask the question?
Sure.
So you compared the lack of hygiene awareness in COVID-19 as a trigger to spread the disease. Yet comparing that to obesity or smoking is kind of make me wonder that maybe we should just raise the awareness of the population just to know how harmful it can be, because I have the sense that it's not really something that the government or the media really emphasize. They're more emphasized about the damages that it caused, but not much about how we can, you know, fight it back, or what can we do to really improve that, just not just the lockdown, but more than that.
Well, again, I assume you're way more expert than me. I mean, that's politics and sociology issue. I mean, I have no clue. That's getting way into more your domains than mine. I can only give you the simple fact, and the simple facts are that very early steps taken that drastically reduced the number of contacts, which means the number of times that people are in contact in a non-hygienic way, so too close, or eating together, or drinking from the same cup, or anything like that. The early steps taken to raise the level of hygiene and do basic social distancing already stopped most of the disease, almost everywhere. Now you can say, well, that's great, then let's educate everybody how to be this way. Well, I tried that with my kids for the last 20-something years. It's not really easy.
Yeah. Question, if I may. Do you have any notes on how to collect data during an epidemic, or any ideas how to improve data management from your experience for the last 2 weeks?
2 weeks ago, and Yanko can testify that, we were really depressed in Israel about how biased and how bad was the data gathering in Israel. So I can tell you that in Israel, we're learning really fast. So now data is already way, way better organized than it was a few weeks ago. And now when we compare ourselves to other countries, I think our situation is one of the best. So we really have learned over the last few weeks, both the Minister of Health and the hospitals and the HMOs, so the Kupot Cholim, have learned that they need to be consistent with the way they define data sets. They need to be consistent in the way that they have definition for sick people, for the symptoms they did define, and so on and so forth. And I think by now we're data aware enough that our standards of measurements are quite good. Definitely compared to 2 weeks ago in Israel, and also compared to most countries outside Israel.
If there are no other questions, there were a couple of questions regarding the trade-off between the economic loss and saving lives, which I answered on behalf of you, Yoram, that this is something that you don't consider yourself as an expert, but you're not, Yaron. I believe that there is a class touching that issue, right?
So it's an important topic. And again, I'll repeat what I said like 10 times. The slides I've shown you were facts. And now we're discussing more ethics. So the expected lifespan of people dying from COVID is less than a year if they didn't have COVID. So saving one person that has COVID is a lifespan gain of a year. Now let's take Israel, for example. In the worst case scenarios, now that we really know the parameters, you would have expected 10,000 people to die from COVID if life would have gone like usual. 10,000 people mean 10,000 life years, because these people are typically very old people, and the expected extra lifespan they had if they would not die from COVID would be around a year. Now the average cost, and again that's gross numbers, but the approximate cost of COVID to the Israeli economy was around 100 billion shekel, which means that we've spent 100 billion shekel to spare, in the worst case, 10,000 year life, which makes an estimate for the cost of 1 year life of 100 billion divided by 10,000, which is 10 million shekel per year life. Now that's obviously way more than we do for other ways of preventing death. Again, like cancer, obesity, helping people be more fit, accidents, and so on and so forth.
10,000 people, it's only directly from coronavirus. What about the people which die not directly from the coronavirus, that like a young man that have appendicitis and is come to the hospital and die because nobody can?
No, so I'm saying that if you would not have taken any measure, then the coronavirus would have costed us 10,000 human life years, which you can say is a lot, but in the total population of Israel, it's around, divided by 10 million, it's around a third of the day less lifespan per person in Israel, which is not a lot. So the question is now, would Israel be willing to pay 100 billion shekel for everybody to live, I don't say 1 day more, but 1 week more? Okay, so obviously if somebody would ask the question this way, everybody would say no. But that's not how the question was asked. The question was asked in the opposite way. It was said, we're all going to, I mean, tons of people are going to die if we don't take extreme steps, so we must take extreme steps. Only a posteriori, the governments and most governments worldwide realized that actually the scare was not as scary as it was.
Okay, thank you so much, Yoram and Yanko. Obviously, this is a super interesting, fascinating, stimulating topic and lecture. So we really appreciate your time. And I'm sure everyone at least has 1 or 2 more questions to ask, but our course needs to end at 2:30 and we already pushed it a little bit further. And just to give you a general answer about the economic questions, then yes, we have several sessions talking about financial and economic impact of the COVID. I also want to thank Sivani Shiran, who gave her a session earlier. So Yoram, Yanko, and Sivani, we really appreciate it. You gave us an amazing opening for this course. And for the students, thank you. You were so engaged and interactive. That was really, really exciting to see from my side. And I'm sure I'm talking also from on Miron's behalf. And before I say final thank you and goodbye, I would just want to say another note about the assignment. So the assignment for today is already on the Moodle. In general, every week we'll post the assignment after the session is over. We wanted you to see already how it looks. So the questions of the assignment every week will be related to the lecture and or to the readings provided by the lecturers. And you will have to submit the 1 page. All instructions are really detailed in the Moodle syllabus and email. You will get a link to the video of the session, so that will assist you if you want to go back to the material or to the class, or just, I'm sure, personally for me, I want to watch again Yoram's fascinating presentation, so you can also do that. And anything else dramatic you want to ask now, or Yoram or Jacob, you want to say before Neil on any final note on your behalf?
No, I would just want to thank Yoram too, and I'll see everyone in a couple of weeks.
And I'll thank Jacob too for everything actually, and good luck with the remaining of the course.
Thank you guys, thank you. Shabbat Shalom. Niron, do you want to say something?
Just to tell everyone, thanks for coming, and next week, 12:30, we start with Dan Ariely, so please be here on time. The show continues. Keep safe. Most importantly, keep safe, even though we have learned that the lockdown was not so effective.
Yes,
okay,
I hope no one from the press is on the list of participants. So on this note, Shabbat Shalom to everyone, and thank you again, Yoram, Yanko, and Sivani.
Shabbat Shalom.
Shabbat.
Thank you. Shabbat Shalom.
Bye.
Shalom.